Dear Mr. Chairman, ladies and gentlemen, thank you very much for the invitation to give this talk about the assessment of liver function for extensive hepatic resection, and I will focus on colorectal metastasis. You all know that there is hardly an exact definition for liver failure after resection. Within the past 10 years, there have been more than 50 definitions of liver failure after liver resection, and here are three different definitions. You all may know the 50-50 criteria, PTZ below 50% and bilirubin below, higher than 5 mg% on post-op day 5. This shows a mortality of 50%. And 2 years ago, there has been another definition by an international study group of liver surgery. They just said that increased ENR and hyperbilirubinemia on post-op day 5 is a definition for liver failure. So there's no clear definition. And we also have no exact data what we shall measure and where we have to go on. There's one slide from Alfredo Giuelmi saying that in normal liver, maybe the remnant bigger than 20% is enough for safe resection. In steatotic liver, maybe we need 30%. But we all know that liver volume is not the only cause of liver failure after resection. And you see here one comparison of extended right and extended left hepatectomy. In extended right hepatectomy, the remnant is much smaller than in extended left hepatectomy. Usually in extended left hepatectomy, the remnant is double the size than in extended right. But mortality in literature in extended left is double than in extended right. So volume is not the only cause of liver failure. And you all know that there are a lot of several factors inducing liver failure, like age, diabetes, cholestasis, steatosis, and of course a lot of surgical related factors, bleeding, hypotension, liver ischemia, and so on. And especially in colorectal metastasis, we have to deal with damaged livers after chemotherapy. We have to deal with steatosis, steatohepatitis, or with blue liver syndrome after oxaliplatin. So we cannot say liver volume is liver function. We all know this. But given the fact we had a normal liver, what is the remnant we need? Is it 25% of liver volume, or is it 0.5% of body weight? And even if we knew this, how shall we measure? There has been one paper from the group of Capozatti by Ribeiro comparing measured total liver volume by CT scan, MTLV, versus estimated total liver volume calculated by the weight and the body weight ratio. And you see it's not the same. Only in 11% of patients, M total liver volume is the same like the estimated total liver volume. But in more than 60% of cases, you see it here, the measured total liver volume is smaller than the estimated. And especially in patients, in obese patients with a body mass index greater than 30, we have a lower estimation, a lower calculated liver volume if you measure it by CT scan. You see it here. There is significant difference when we measure it in CT scans, then we compare it to the estimated total liver volume. And those both methods were compared with regard to the need for portal vein obstruction, either ligation or embolization. And in 85%, both methods were concordant. They found a need for portal vein obstruction in 42 patients and no need for occlusion in 165 patients. Here are the data. When there was no need, there was hardly any liver insufficiency. But if there was a need suggested by estimated liver volume and not by measured liver volume, in 11%, you see it here, and they did not occlude the portal vein because they relied on the measured volume, then they had an amount of liver insufficiency of 6 patients. Where is the 6 patients, meaning 22%. This was significant. So saying that in a few patients, about 10%, the measured total liver volume does not exactly predict when you need portal vein occlusion, and this is mainly the truth if you have very small patients with a body mass index below 25%. So measurement of liver volume is not clear. Shall we measure it by CT scan, or shall we calculate it by the method shown now? So meaning quality of liver parenchyma, maybe by steatosis and cholestasis, impairs liver function, so liver volume is not liver function. And also variations of liver anatomy is very high, so remnant liver volume is not the same like the perfused remnant liver volume. You all know that we have a lot of anatomical variations. We rely usually on the Quinu model, on the CT scans, but we have many anatomical variations. There's no reliable assessment of the vascular territories in 2D CT scan, so we cannot say that the remnant volume is the functional volume. Looking at this slide, this is 3D reconstruction of liver anatomy, and you see a lot of variation here, a small hepatic vein, middle hepatic vein, a large middle hepatic vein, an even larger middle hepatic vein, just a tiny right hepatic vein. So there's a lot of variation, in particular in the venous system, but also in the portal vein system. And when we do resection of colorectal liver metastasis, just with a safety margin of 1 centimeter, and just excise these nodules, then we might have impairment of perfusion. Here, portal vein perfusion, and we cut this metastasis with a safety margin of 1 centimeter here. We have to cut the right hepatic vein, and this area will be without venous drainage, so it's a large area. And taking this together, more than 550% of the total liver will have an impaired perfusion, either because of impaired portal vein perfusion or impaired venous drainage. So it's much more impairment than we remove of parenchyma. Or see here a left hepatectomy. When we plan it in 2D CT scan, we do a resection line like this. This is the resection area. This is the total remnant. It's this is the total liver is 1,415. This is the remnant, but 228 milliliter of the remnant, the blue area, is without venous drainage because we have to cut the middle hepatic vein here. So this is not too much in this area, but if you do extended left hepatectomy, then probably 30 to 40 or even half of the liver parenchyma will be without venous drainage because sometimes we have a dominant middle hepatic vein. So mainly the cause of impairment is impairment of venous outflow obstruction because of a dominant middle hepatic vein. And I show you one example. This is a cholangiocarcinoma. It's not colorectal metastasis. It's located in the middle of the liver. We cut it like this. We have to cut here the middle hepatic vein. This is the cutting surface. This is the remnant. The remnant is a little bit more than 1,000 milliliter. And the blue area, almost half of the liver, is without venous drainage because we have to cut the middle hepatic vein here. And in these cases, we sometimes do venous reconstructions to optimize hepatic venous outflow because we all know from living-related liver transplantation that venous outflow is crucial for impairment of liver function. So finally, coming to the liver function tests, and there has been a very good paper from the Fanguli group last year in Annals of Surgery, and they differentiate between 4 different groups of tests. The passive liver function tests, this is just laboratory data, bilirubin, the clotting factors, and so on. I need not comment on this. The scoring systems, they take together the passive liver function tests and some clinical data like ascites and so on. This is the Child-Pugh classification and the MELD score. They mainly focus on HCC, on liver cirrhosis, and I need not comment on this in the context of colorectal metastasis. Then we have the dynamic liver function tests. They give information about global liver function, and I just want to comment on the IgG test and the LIMAX test. IgG, you all know, depends on hepatic blood flow, on the uptake of IgG in the liver, and on biliary excretion. There's one paper by Imura and colleagues, but they also combined the test with some clinical data. They exclude patients with uncontrolled ascites, and they also exclude patients with a not normal bilirubin. And if they have a normal bilirubin, then they rely on the EGG test. And then if they have a normal excretion, meaning excretion more than 90%, then they say the patient qualifies for even extended right hepatectomy. And if they have only 60% excretion or a remnant of 40%, then they say just enucleation of the tumor is possible, but nothing more. And by differentiating in this way, they have a zero mortality rate and zero liver failure rate after extended hepatectomy. Now one new test from the Peter Neuhaus group in Berlin is the LIMAX test. LIMAX test is based on intravenous giving metacetine, and then they measure CO2 labeled in the expiring air. They did first a retrospective analysis and found that the LIMAX test is predictive of liver failure-related death, is predictive of liver failure, and also is predictive of severe complications after hepatectomy. These were the results of a retrospective analysis. And then they started to do it in a prospective way. They calculated the LIMAX, and they also did a volumetric analysis. They did an analysis of the future remnant, and then they calculated the LIMAX test in the future remnant. Here you see calculated future remnant LIMAX test 165, measured 6 hours after operation, 1 hour 169. So there was a good correlation, and they did this in more than 50% and found a good correlation of the LIMAX test 6 hours post-operative and to the preoperative calculated LIMAX test. And so they said this is a parameter that can predict liver failure, and they now make a strategy based on the calculated LIMAX test after liver resection. If they have a LIMAX test below 80 microgram per hour per kilogram, then they say resection is very dangerous. Look for alternatives of resection like RFI. If they have a LIMAX between 80 and 100, then they say it's a critical resection. Try to avoid intraoperative inflow occlusion, try to avoid hemorrhage, and so on. And if they have a LIMAX test bigger than 150, then they say we can do a regular resection. And these data are based on the numbers they had. If they have a very low LIMAX test, in-house mortality was almost 40%. If they had a LIMAX between 80 and 100, it was 10%. Between 100 and 150, it was 2.4%. And bigger than 150, they had a zero mortality. So this seems to be a very reliable test to predict liver failure after resection. And what I found interesting is that they also use the LIMAX test to predict the date for the second operation in ALPS. They did an everyday measurement of the LIMAX test, and when the LIMAX test was okay, then they said it's time to do the second operation in ALPS. So I found this interesting. So finally, coming to the last imaging tests, to the dynamic imaging tests, and I just want to show one test, the TC meropenem hepatobiliary scintigraphy. There's also been one paper from the Frangulik group. You see here the scintigraphy and here the area under the curves. Meropenem is a product that is not metabolized in the liver, but it's biliary excreted. So it just measures the biliary excretion. And to measure it, you have to use 3 different areas: a pooling area over the heart or mediastinum, an area over the total liver, and an area over the future liver remnant. And just the definition is the uptake is the increase in blood pool corrected uptake of TC meropenem over a definite time period. Usually they take 200 seconds. And this just here the uptake within 200 seconds. And they could show in 2 papers that there is a clear cutoff point for liver resection. If they have an uptake bigger than 2.5%, or 2.7%, I'm sorry, this is a mistake, 2.5 or 2.7, then the risk for liver failure is below 3%. This has been shown in 2 studies, and they even could show that this test is a very good test to evaluate liver function after portal vein embolization. It seems to be much better than just pure calculation by volumetry. These studies have all been done by the group of Thomas van Gulik. The only smaller lack of this test is that in scintigraphy you only can measure regional liver function, but if they combine the scintigraphy with the SPECT analysis and do the 3D reconstruction of the liver and then the scintigraphy, then they can also give a measurement of segmental liver function. So this test seems to be the best test at the moment to measure liver function of the future liver remnant. So in final conclusion, we don't have a test that gives us an exact data of the future liver remnant. Volumetric assessment alone seems not to be sufficient because of anatomical reasons. The remnant volume is not the perfused remnant volume. Sometimes we even don't know, shall we measure total liver volume or shall we calculate it? And of course, the quality of parenchyma, steatosis, and post-chemotherapy injuries reduce liver function. We have the liver function tests, LIMAX and IgG. They give us information about global liver function. LIMAX test is very new, probably needs further evaluation, but I think there's good news that we probably have a good test to predict liver failure after liver resection with a LIMAX test. And the TC meropenem hepatobiliary scintigram measures the uptake and excretory function of the liver, probably is at the moment the best test. And maybe we shall say that we need to assess the function of the liver, we need a volumetric assessment, and we need in addition one test, either the LIMAX test or the TC meropenem scintigraphy. Thank you very much.